Okay, so really kind of warm welcome to everybody for taking time out of their day and particularly to our presenters today. We really appreciate you taking the time to come and talk to us. So my name's Zoe. I'm the Chief Executive of Healthwatch Bucks, and I'm joined by my colleague Fiona. Do you want to say hello, Fiona?
I'm on mute. Apologies for that. Hi, I'm Fiona. I'm Public and Patient Experience from Healthwatch Bucks.
And so our webinar today is looking at teamwork within general practice and looking and hearing from some of the people doing some of the additional roles within general practice. The webinar today is being recorded, so if you and we will have it on our website, so please do turn your cameras off if you don't want to be seen on screen. And if I could just ask everyone to keep their microphones off as well, that would be great. I'm going to hand over to the speakers in a moment, but there will be an opportunity for you all to ask questions at the end as well. So without further ado, I'll hand over to George, who will be starting the presentation today. Welcome, George.
Thank you, Zoe and Fiona, for inviting us to give this presentation. I've got some fantastic healthcare workers with us today who I'll introduce as we go along, and hopefully by the end of this we'll have a clear idea about what some of them do and how they can support you in general practice. So I am George Gavriel. I'm the director for Bucks GP Provider Alliance, but actually today, more importantly, my role would be as a GP and a primary care network director. So in terms of what we're going to cover today, we're going to have a look around the history of general practice teams and something called the Additional Roles Reimbursement Scheme. You'd have heard affectionately called the R's. And then we're going to talk about accessing general practice and how that's changed very recently, and then go through a few specific patient cases to try and bring some of this to life for everybody. So general practice teams, there's been the kind of long established basic general practice team, which to be frank, probably went from about the 1940s right up until the early 2000s, and that team was the GP, a nurse, perhaps some specific types of nurses like district nurses at that time, and a receptionist. And actually not a lot changed until around 2000s and the early 2000s, when there was a new GP contract, and that contract had a much greater focus on the role of general practice in managing long-term conditions. And that's when you start to see the evolution of those nursing roles to becoming chronic disease nurses, and what you will now see frequently and is very accepted as a normal part of general practice, people like diabetic nurses, COPD nurses. Then in the early 2010s, we started getting a shortage of GPs. We saw the sort of requests for GP appointments more than double, and we saw the number of GPs very slowly but significantly reduce along with the number of practices. And so we started to see some of the more innovative practices bringing in their own professionals to support GPs off their own back, really. Probably the earliest of these would have been advanced nurse practitioners or minor illness nurses. And then some practices would start bringing in clinical pharmacists, visiting paramedics and care coordinators. So visiting paramedics to sort of take away some of the burden of the home visits, which are quite time consuming, although very important, and care coordinators to make sure that the care for the most complex patients was essentially being managed appropriately. Then in 2019, apologies for my missing capital, we saw the introduction of the primary care network contract, or the PCN contract, and within that we saw outlines of a vast swathe of new professionals working in general practice. It has evolved over time, but this is the current list of professionals who are covered by the Additional Roles Reimbursement Scheme. Essentially, this is a list of people that each primary care network can employ and receive reimbursement up to a set level for each role. You'll see that more recently we've had the introduction of newly qualified GPs and practice nurses into that. But actually, when the scheme started, it was really about additionality, providing additional people into practice and encouraging GPs to work with a much wider range of professionals who have sort of vastly diverse skills, some of which are not skills held by people who are already in general practice. So what we've got today is a system where we've got lots more people working in general practice. And one of the key things that we started seeing happen is inefficiencies in the system. So everybody would be still going through a GP first before they could get to these roles. And actually what that meant was a lot of double handling, and it didn't really provide the extra capacity that people were after. So this system called Modern General Practice was brought in. It's been called the end of the 8 a.m. rush. I certainly hasn't delivered that yet, but we're sort of heading towards there. In 2024, there was incentivization for practices to provide a consistent approach to triaging all requests at general practice and to provide a forum for simple online requests. And from October, so just 3 months away, there will be an obligation on all practices to have a digital front door, so some form of online triage. There's also, just for information, going to be a new patient charter which says these are the obligations of a GP practice for its patients, and these are the obligations for a patient in terms of, you know, looking after themselves and accessing care appropriately. There's also going to be improved data sharing, and all patients are going to be stratified, so there will be essentially a clever stratification based on the notes to sort of say how risky is this patient, essentially what's their background frailty. So modern general practice, and a lot of you will see this as kind of, you know, what is happening now, and I suspect will become the norm across the whole country very soon. Someone wants an appointment, and whether they access the surgery via the phone or via the internet or walking in, their information will be gathered and put into some sort of online consultation tool. That's the term used in practice, not particularly patient-friendly term. And then a team or an individual within the practice will then suggest the appropriate waiting time and professional for that person to see, and hopefully get the patient to the right person first time. So what we've done today is given a bit of an example of 3 cases and what we might do if these cases came in. And then we will speak to the professionals who might see those people. So case 1 is Janet. Janet's 68, and this is the text that Janet will have put into the online system, or what she would have told the GP receptionist who's put it into the system for her. She's been feeling a bit dizzy and starting to get cramps in her legs, and she thinks it might be because of her tablets, but she's not sure. And she's told us what tablets it's taken, although obviously the person doing the triage will be able to see that from the notes. And she's been stratified into a sort of moderate risk. So she's got a couple of long-term conditions, but otherwise she's pretty fit and healthy. So in this case, where, you know, it really does look like it's the tablets that are the cause of the problem, as a triaging GP, we'd probably be looking to arrange a detailed review of her medications, and we'd be looking for a clinical pharmacist as the expert in the practice in medications to be the starting point. So I'm going to hand over to Rimple to introduce herself and talk us through the case.
Perfect. Thank you, George. So I'm Rimple. I'm a clinical director for Mid-Chiltern PCN, but I'm also a senior clinical pharmacist. So I've been working in general practice for some time now. And when we often get presented with cases like this, and the first things we kind of do is assess whether it is the medication that's causing her dizziness or her leg cramps. So the first thing we may want to do is check her blood pressure. And we'd do that by either getting the patient to come in, so we can do like a sitting and standing blood pressure just to see if it's okay. And then we'd assess for sort of any leg pain or any sort of thing that's causing that pain in the leg. So has it been an injury? Has she had a fall? So we'd look at something like that. We would also check if there is any interactions with her medication. So has she been compliant? Has she been taking her medication properly? Does she kind of buy anything over the counters that might interact with what she's having? So we'll be doing this thorough history with the patient, and looking to see if we can identify that there is a medication that's causing this issue of dizziness. And I think what I'd say is that if we did find we did find what the cause was, and if it was maybe her blood pressure pill is too high, and we tried to look at stepping her down to like a half the dose, and then reviewing her sort of 3 to 4 weeks later to see if she's got any sort of concerns. We'd do something like that. If there was anything else that we would feel needs adding in, we could do that as well. And if we find that after talking to the patient, we can't ascertain what's causing her leg pain or the dizziness, and it's nothing to do with her medication, it's nothing to do with her blood pressure, then we would be speaking to the GT doctor and passing them onwards so that they get assessed appropriately. So that's probably what the patient journey would look like. And I thought I'd also kind of summarize what clinical pharmacists do on top of all this triaging cases that we do get. So we can get patients flagged up by GPs, or we sort of assess for people who are frail, and we review patients' medications just to make sure that they're not being overprescribed or underprescribed or taking anything inappropriate with their health conditions. We help manage long-term conditions, so we manage people with their cholesterol, their high blood pressure. Some pharmacists are skilled up to do heart failure reviews, asthma reviews, COPD reviews. So a whole array of conditions that we can help with. We're also the medication experts in your GP practice. So if there is any medication-related query, any interactions, any questions around that, that comes through to the clinical pharmacists. And because we're positioned in such a way that we are very medicine focused, we also look at where evidence has changed in terms of prescribing medication. So we do lots of education training with the GPs and all the other members of staff in the practice to make sure that we're all prescribing in line with good evidence. We work alongside, as I said, nurses, paramedics, doctors, care coordinators, anyone to support them with patient care, planning, anything like that. And then some of us have done a university degree where we've become independent prescribers. So we can also prescribe medication within our competencies. I will pass this back on to George, but I think there's questions at the end of it, and I hope I've done a good summary.
Yeah. So thank you, Rimple. Obviously, we'll take questions at the end if you've got any for Rimple specifically, or any of the other speakers. So we're looking at a second case. Second case is Rebecca. Rebecca is 34, and we'll kind of skip to the bottom in what's called patient needs group 1. So no long-term conditions, healthy, nothing in her medical records of concern. And she describes a situation where she's been bitten on the ankle by a mosquito, and it had been itchy, but over the last 2 days it's become a lot more painful and becoming swollen with redness spreading up the legs. She's feeling okay at that point with no fever, but she's worried it's getting worse. So as someone triaging, you're sitting there, I can say as the doctor, you're sitting there saying, oh, is this just a local reaction to the bite? But there's definitely a risk that this could be an infection. So you're thinking this person definitely needs to be seen. And the most appropriate person in this case would be one of our sort of choices of first contact practitioners. So I'm going to hand over to Helen to introduce herself.
Thank you, George. Hello, my name is Helen, and I am one of the first contact practitioners at the Swan network. I am a paramedic by background, but we also have some advanced nurse practitioners on our team, so we cover a wide range of things. And we tend to be triage the patients who are suffering from an acute or new illness or injury, because we're able to manage those mostly. So for this lady, I would want to see her, partly because it sounds like it's possibly now infected. So I'd want to see her bite itself and assess that, but also check her over and make sure that she's well enough to be treated by us in the community. So once I decided that if it was indeed infected, I would give her a course of antibiotics to treat that infection, along with some information about what to expect in terms of how long it will take for her to get better on antibiotics, but also if things do get worse, what to look out for and how to seek urgent assistance if that does happen. And just a little bit about what our team does. We kind of, as I said, we assess and manage all the acute on the day things or people who are newly ill, and we take responsibility for those patients and organise any further tests that are needed or treatment that needs to be given on the day and any further referrals that might be needed. Again, in our team, quite a few of us are independent prescribers now, so we can give medication to all the patients that we feel need that medication. But those of us who aren't prescribers within the team, we have a GP support so that we can run the patients past the GP and ask them to prescribe for us if they agree with our diagnosis. So yeah, we work under the supervision of a GP every day. Part of our role in our team as well is to help with the clinical triage. So all the requests that come in from patients, there's a team of us that look at those and decide who are the best people to see that patient and how quickly. So we help with that as part of our team as well.
Thank you, Helen. So moving us on to the next case. The next case is regarding Louise. This is something that we can see immediately is a less urgent but still really important thing that we want to support people with. So Louise is 40, and again, no sort of there is some history in her notes, but she's looking for help with losing weight and getting healthier. And she's been feeling a lot lower in energy recently, so she's not too sure what to do and where to start. So she's diabetic. She's actually going to be in patient needs group 5, not 1. Apologies, I didn't update that when we updated the case. Moving on to Molly, we would look in this case to pass on to a health and well-being coach, essentially to both support and identify the best way of helping the patient in this case. So Molly.
Thanks, George. So I'm Molly, the health coach team lead from Aylesbury Central PCN. So typically with this patient, we would look to book them in at a face-to-face appointment and rediscuss their reason for referral. Sometimes it gets lost in translation of what the patient wants to what the referral says. So it's always good to just recap what it is they're looking for, what it is what their priority is, and then look to find the most appropriate support for them. So particularly in our PCN, if they come in for exercise in particular, we've got an in-house exercise referral class. They might want the one-to-one. They might want a group setting to share experiences with other people. So we can offer whichever support is going to most support the patient's needs. We would then look to talk through their current diet and lifestyle and the particular barriers that they feel they're facing. A lot of people have tried diets in the past and typically they haven't worked, and we would explore why they feel they haven't worked and then look to navigate into something that is a little bit more realistic and sustainable for them. We would look to educate them on kind of the overall understanding of how to lose weight in a sustainable and realistic way. We would then look to agree on some realistic goals, which are very much patient-led. So they're never going to be told by us what to do, but if they have a particular area that they want to focus on, then that's the area and the route that we would look to support them on. We would offer regular check-ins with them. So we offer any time between 2 and 4 weeks to catch up again. It will all depend on what the patient has set and how confident they are in achieving it. And then we would look to offer that accountability to come back and review how they feel things have been going, if there's any problems, breaking down any barriers, and then look to continue moving forwards whilst learning along the way. Again, as we go through, we can suggest useful services and using other support within the PCN or practice teams and sharing resources to help with their understanding as well. So typically we support patients with long-term conditions. So anything that can be improved through diet and lifestyle. So whether that's diabetes, high blood pressure, high cholesterol, we know that as they improve diet and lifestyle, the medication can also start to be reduced, which a lot of patients are encouraged by. It's a non-clinical role, but we do work within a multidisciplinary team. So we have access to GPs, nurses, care co's, social prescribers. So we've got a very wide team that covers a lot of bases. We look to monitor their progress and their outcomes, and again to keep educating them to hopefully find that sustainable change that works for them. And again, it's that accountability, sometimes having that somebody to come back to weigh them and have that chat and talk things through goes a long way.
Thank you, Molly. So we have only really showcased 3 of that enormously long list of health and care workers that now work in general practice. I think, obviously we're very happy to take some questions, but in summary, it's really clear that general practice teams have changed and have been evolving for a long time, but have changed significantly over the past 5 years and now involve a huge variety of professionals. Modern general practice, which is not my choice of terms, the NHS England's choice of terms, means that patients will experience a new way of accessing GP appointments. That the movement is from, moving away from the first people to get through at 8 o'clock, getting access to the people that most need it, either because of their background or because of their presentation, and making sure that when they do access the practice, they're seeing the most appropriate person first. I think one of the things that I'll pick up here is, I certainly think a lot more needs to be done around communication and expectation management with the public. That's something that certain the GP leaders in the local area and nationally have been sort of lobbying for. Practices have Facebook pages and do lots and things on that, but to be frank, we don't get a lot of traffic on those sorts of things, whereas we think there can be some more done to try and support people to understand a bit better how they'll be cared for in general practice. And the 10-year plan means that this is going to expand. So neighbourhood working is a new term for providers like GPs and hospitals and the voluntary sector working together, and this MDT approach will move across all of those. So I think what we will see in a few years is everybody accessing through one place. We're told it will be the NHS app, possibly 111, and then being triaged and care navigated potentially to different types of providers. So this is likely to spread for professionals, not just within general practice, but also in other providers. So happy to take any questions there.
Thank you, George, and everybody. That's really, really helpful, and I'd certainly echo the bit about further comms, because something we hear a lot about at Healthwatch Bucks is around access and roles and general practice, and I know that people watch these webinars back as well after the event. We put them on our website, so yeah, really grateful for you coming along today. We do have one question that we can start off with in the chat from Anita that says, will stratification lead to patient tiered care?
So I think what it will lead to is different patients getting a different experience of care. So put simply, we need to take more account of the patient's history and background in both allocating the care professional who will look after them a specific incident, with a specific presentation, but also in considering how urgent that becomes. Somebody presenting with a cough with a history of COPD or with significant frailty is at much more risk of significant consequences of an undiagnosed, either an undiagnosed chest infection, but even a viral infection. And also people in the higher patient need groups have got generally a lot more medical conditions, and that's where that complexity sort of leads itself towards professionals who are used to dealing with that complexity, possibly the GP, but people like clinical pharmacists are dealing with a very high level of complexity. So I don't think it will be tiered care. I think it will mean that we get people to be appropriately prioritized, and I think we will see more and more people who have maybe no significant medical history being looked after by professionals and organisations that are outside of general practice. So we haven't talked today about the Pharmacy First scheme with our community pharmacy, but even that case that we brought here, you know, that's the type of thing that, you know, in a patient needs group 1 patient like we put here might be very appropriate to go and see a community pharmacist rather than come into a GP surgery and see someone like Helen. But somebody in the patient needs group 10 with that, you definitely wouldn't want to be seeing that in the community pharmacy, because there's a lot of complexity behind that, and having access to the records is really important. So hopefully it'll be more about the appropriate person seeing each patient in the appropriate time frame and the appropriate way.
Okay, thank you. Any other questions? Lisa. Hi,
Chloe,
Lisa.
thank you. Hi, can you hear me okay?
Yeah.
Brilliant. George, thank you ever so much. It's really given me a sort of a better insight around sort of roles and responsibilities within sort of general practice. Just a couple of queries, and it's all about sort of practicalities, really. So within the 10-year plan, it talks about sort of embracing innovation and digital access, etc. And looking at the format as it currently is of sort of e-consult and those sort of platforms that the GPs are using, is it a standard format per practice and that are all the same? I don't mean EMIS or Vision or anything like that. I just mean the actual e-consult form.
So I think this is a really important issue, actually, you've raised, Lisa. So no, at the moment, it's not a standard form. It's not a standard format. And the platforms that are available, they're essentially all commercial platforms. You know, I could probably rattle off 10 different commercial providers that are being used across Bob at the moment. The patient experience of each is vastly different, and the clinician experience is vastly different. And it's a really difficult balance. If I give you an example, there are some platforms that require patients to fill in hugely long forms, and they're not very patient friendly. You know, they're really asking people to invest a significant amount of time into completing the boxes, the information. But what that does is it gives a real richness to the triaging clinician to help them make a better, more appropriate decision. On the other side of it, there are some where there are just 3 boxes, which essentially say, you know, what's happened, and what would you like to come from this encounter? And that gives a lot less information for people like Helen and I who would be triaging, but also, you know, is much more much more straightforward for people to use. So I think that's a question that's not been answered yet, is finding that kind of happy medium. And at the moment we've got so many solutions, and once you invest in one, it's really hard to change. I think that needs addressing. The alleged solution to this will be the NHS app, which apparently will use AI to for people to essentially put their information in there, and then some sort of triage outcome then directs you into the most appropriate person, whether it be community pharmacy or it feels widely optimistic, doesn't it, that we'll be able to get something like that in place, but it would provide that consistency that, you know, everybody's having the same experience in every part of England.
Yeah, I think, I mean, I'm, you know, not a whiz kid techie, but I do get around, you know, day-to-day activities. And even as a patient myself, the e-consult platform that my GP offers is very thorough. And I often feel that I'm repeating the same information. So they say, what signs and symptoms do you have? You put it all in. Next question is, how can we help you? Well, I've just kind of covered that because of my signs and symptoms. So I get that there isn't a standardized, you know, or it's good to know that there isn't a standardized, but that could be something, you know, to build upon, particularly if we're all supposed to be embracing the digital element, but also concerns around digital exclusion as well. So, I mean, you'd like to think in an ideal world that will then free up time for receptionists and obviously face-to-face appointments where those that aren't able to get online to ask their questions and raise queries. But yeah, I think it's quite visionary, and I think we're quite a long way off that.
Yeah, so just to bring back in this this slide, the theory, I don't want to say it works, is that by pushing people into digital, who are able to do it, but you then free up the reception resource on the phone and for walk-ins to be able to complete that for people. It's really interesting. I mean, I can a little bit sort of specific, but if I talk about our practice, you know, we're now looking at moving to a simpler platform, which will not give us as much information, but actually has a really good interaction capability. So it allows us to have a dialogue with the patient. So less information is put in at the beginning, but we can then send, say, a questionnaire out saying, okay, it looks like you've got a urine infection. We need a bit more information. Could you fill this in? And it might allow us to treat you without even needing to see you, for example. So there are lots of different ways of doing it. It's definitely evolving. I think there's generally a movement towards slightly simpler forms. That's what we're starting to see. And the other thing is that the Integrated Care Board, who essentially fund healthcare in the area, have to provide a tool for the whole of general practice. And the decision they've made is to provide a much simpler tool. Previously, eConsult was one of the 3 tools that was provided, and that's no longer going to be available from the autumn. So practices can choose to pay for it themselves, but if they want the funded version, they have to go for the simpler one.
Thank you.
Thank you. Any other questions? Hey, Anita.
Hello.
Hi,
Some
Anita.
of you may know me, but I've just retired from the NHS as PCM manager and that. But what really still worries me is that can you please stop calling our front of house receptionists? They haven't been receptionists for a very long time. They are care navigators, and they are very trained in this and have been trained in the last 2 years in order to simplify this digital transformation for our patients and point everybody to the correct person within the organisation when somebody wants an appointment. Okay.
So I'm going to slightly challenge that, Anita.
Are
You don't
you?
need a bit of challenge. In that actually there has been a movement away from care navigation because of these online tools now. So previously, in practices that are now fully using these digital tools, they have moved
Are
back
they though,
towards.
George?
Well,
Are
some
they?
are, yes, so
Yeah,
certainly.
some are.
So
Okay,
what?
some are.
So
That's what I'm
Anita,
saying. So
okay.
yeah.
So I think what's important, you know, I'm trying to use language that's understood by people. It's fair to say that yes, absolutely. A lot of the work done by the online tools and the triage tools have been done by care navigators over the past, probably the past decade or so. That's when that movement started, around 2016. So, you know, I think there are lots of terms that are interchangeable, and I think that's one of the kind of challenges around this. So yeah. Certainly there's been a movement to using care navigators as a term. It's not a very patient friendly term. It's not one that's been well embraced. And so I think there's a number of different things that are being used for it now. But yes, fair, absolutely right. And care navigators are certainly much more trained and skilled than traditional receptionists would have been historically.
They've all been upskilled. Well, majority of front of house are upskilled. They've never just been receptionists.
No.
Never. And it's a terminology that really needs to go in the modern general practice as we keep going. So, and they get enough bashing without, you know, it's a very difficult job, and they are very, very knowledgeable. And even now, with all embracing all the different roles, additional roles that have come into general practice, they are a real font of knowledge. So, hello, Robert. Okay.
Thanks. Thank you, Anita, for that challenge. Frank.
Hi, George.
Yes, Frank.
Digital exclusion and the 8 a.m. rush. I know the theory, but if care navigators, receptionists, whatever we're going to call them, are now, instead of just taking a phone call and talking to the patient, are required to complete the e-platform document, that's going to take them some time. It's going to extend each individual phone call, I suspect. How is this actually going to ease the 8 a.m. rush? And second part of that, if I decide instead of coming on at 8 o'clock, I'll put my message through at 11 o'clock, either by phone or by directly on an e-form. Will it be seen the same day, or will we just close down the e-form access when we're full, when the in-tray is full?
Yeah, so I think both absolutely fair challenges. I think what we're seeing is some places call times are waiting for that reason, and I think that's why a lot of places are working quite hard to move people to the digital side, in terms of if you can do the form yourself, it frees up our teams to support people who need extra help. I think there's also a lot to be said about the simplicity of filling the forms in. We talked about for patients and people in the public, but also for the reception teams, because if there's a 10-box form or a 3-box form, it's going to take longer for that to be filled in. So that's all being worked up now. I think realistically, we've kind of got two challenges. If this worked, then you would absolutely remove that 8 a.m. rush. I think the challenge we've got at the moment is still capacity. So there's still a demand capacity mismatch. And I think until that demand capacity mismatch is addressed, you're still going to have what you're seeing, which is practices turning off their platforms because they just don't have anywhere to put people on the day. There is a requirement to keep the platform open for routine questions and queries and requests from October, but the technology by then should be able to separate those out, but it'd be interesting to see whether that comes about. So, if a practice has nothing to offer for that day, and that does happen consistently across Buckinghamshire, then there will be a redirection, and we're very lucky to have a somewhere that people can go as an alternative. But if you just want to request your long-term condition review or your medication review, then actually the fact that the form is turned off because there happens to be nothing available that day is not very helpful. So I think that's the next step you'll see, is that the form will remain available for people who have a routine question or request, even if the on the day capacity is gone. But at the moment, that's not what's happening.
Thanks, George. Thanks.
Thank you. I can see a bit in the chat about a suggestion about further marketing per practice around roles when we're thinking about receptionists, stroke care coordinators, care navigators. But does anybody else have any other questions? No? Are you sure? You get lots of questions at Health Watch. Please take the opportunity to ask George them while you have him, and Molly and Rimple and Helen.
Do you know what? It's Deb's here, Deb West.
Hi, Debs.
Hi. This is really great. I love this because it's so informative. Particularly for our patients on the PPG groups. I mean, it's great, George, and that. So it's just for me, it's one question, I suppose. The opportunity to speak to George while I see him there is, I know this, I think we've come personally from what I've seen and hear and various things, that we've come a long way in a very short period of time with digitalization, with the uptake of the NHS app. When you think about when we first got it and now we are where we are now with it, and then obviously moving on to this total triage and various things like that. And I think we're, particularly sort of where George and his teams are involved in, they're sort of taking that innovation step quite quick, sooner than most people. How much influence do you think, George, are going to get as clinical and professionals on how we do adapt and go forward with how the public's perception on how they're going to be, if you like, treated, triaged, and the different patient groups? I mean, we are talking about patient need groups and stratification and all those things that and AI and all of that's coming into play. And I suppose it's around the communication piece around it. How are we going to get that over to the general public at all various age groups as well? Because the young obviously have a different understanding of what they think about AI, for instance, to what, you know, possibly my age group or various other age group, we're still grappling with AI, and that means something totally different to us. But as a clinical professional team, where does that influence sit? Where are we going to be able to influence? Just by saying, even just having standardization across the platforms that we use and the triage system that we use and the language that we use on that. It's a bit of a blue sky, but I just think, you know, how are we going, you know, the clinical professional going to influence what's going to go forward in the future?
Yeah, so what's really interesting is if you look at the evolution, so if I just share this slide with you, you know, we essentially had 50 years of the GP team not looking any different. You know, you'd have a receptionist, which was a receptionist then, you'd have a practice nurse whose role did slowly increase, and you'd have a GP. And it's taken 50 years to get to the point that you have more than that, up to 2004. And there are obviously always exceptions. And then it's taken from, say, 2004, 15 years up to 2019 to bring in these other professionals that I'm listed here. There's, again, a few other examples. And then since 2019, we're essentially, you know, so we've introduced 5 new professionals in the 15 years prior to 2019. And then since 2019, we've introduced all of these professionals. And not only that, these professionals have been introduced because in practices there's felt that they are valuable and needed. And this is a list of people that have kind of been said are valuable, we've been told effectively are valuable and are needed. And I would certainly say that every professional on that list has something to offer, but I would say that the degree of value is variable in terms of integrating with the teams, in terms of, you know, I know that, for example, you know, I'm sure Molly will, I don't know if Molly has dietitians working within her team, but I bet she would love to, because how complementary would that be for what you do? But I can tell you the majority of GP practices and PCNs don't employ a dietitian because there's a view, well, actually, this isn't a general practice's job. It's, you know, someone else's job to do it. And I think that's the barriers that are going to be broken down over the next few years. I think there's going to be kind of less of what's our job and what's their job, and the neighbourhood working will bring that about. I think for us as general practice, I think we have a choice as a profession, and not just on behalf of the GPs, but on behalf of our whole clinical teams, of whether we want to engage with that. I want to call it an evolution, but it's a revolution, isn't it? Whether we want to engage with that and try and shape it, but we certainly won't be able to have control of it, or whether and we're seeing that in some areas, disengage with it, and you know, things will evolve how they evolve. But I think the key bit that's quite difficult in all of this is everything's being done with the sort of patient and public at the centre, but I'm slightly concerned it's being done to both us as clinicians and professionals and to the public without the full consultation and sort of engagement that's needed. So slightly candid answer, I suppose. But I actually think there's a lot being done to both clinicians, which is your question, Deb, but also I think just to the public. And unfortunately, people like Helen, I think it's probably still a weekly occurrence of people being either politely or impolitely dismissive of the value of her in the practice, and not really accepting her advice because she doesn't have a medical degree.
Yeah, that all makes sense, and that's all logical, and you can see that evolving. I think when you just that timeline that you've just gone through there, in that short period of time, the way it has changed from professionals joining and sort of coming into general practice is really quite fast paced. And it is, you are right, there's an element of sometimes it's happening to rather than that collaborative piece. But at the same time, it's it's really exciting, and I think we've come a really long way. And I think shall we say, new service users to a practice would be, I think, quite surprised what from a professional point of view that they'll get access to. But it still is challenging if you've never experienced it before, and you go on and you sort of get to that stage, you think, oh, do I make a phone call? Do I go online? Do I use the NHS app? So it is about that communication and how that's going to get out there to the public. And I think all our voluntary sectors and every areas where people that are in that sphere to get that communication right, because that's a really key piece. But I think it's quite exciting times as well. So yeah.
I think there needs to be something coordinated across the country on this, and then I think there needs to be local work on how it's working within an area, whether that be a practice or a PCN or a neighbourhood. I don't think we've had that sort of national programme of kind of communication to enough of an extent.
Great, thank you. Lisa?
Thanks, Zoe. I was just going to add with regards to kind of the public perception and terminology. I think it's no different in secondary care with regards to, the public perceive doctors, consultants, maybe and nurses, and everybody else in between is relevant to their role, but they don't quite know how that kind of fits in. And even, if you go to the most innovative wards and you see posters up of uniforms of what, their secondary care will be given by, people's perception is still just nurses and doctors. So and that obviously just all that list there, I wouldn't necessarily, if I asked any members of my family if they know the difference between, they wouldn't be able to give me a defined answer. So there's lots of work in both areas, I think.
Thank you. Frank?
Yeah, George, going back to the additional roles, anecdotally, there is evidence that since GPs were included in the R's options, that some places are, if not getting rid of the other roles, they are filling their gaps with GP. And of course, the hours thing, it's a GP is the most expensive option, of course. So it needs to be spread across, but there's a kind of a knee-jerk reaction, and there were a lot of people, GPs and patients, calling for GPs to be included in the R's roles. Do you think it's a retrograde step, having gone that way now? Do you think there's a danger that we will slip back down?
So I think there's kind of two parts to this. I think that, so first of all, to give you, I know of a PCN literally over the border from Bucks. It's a PCN that borders Bucks, but I won't tell you which direction, who have and are in the process of making all of their non-GPR staff redundant and replacing them with newly qualified GPs. So yes, that is absolutely happening. I'm not aware of that happening in Bucks, but I think there will be a kind of situation where when people resign, the question will always be asked, who do we replace them with? Although that's a good question anyway. Whenever somebody resigns from our organisation, you have to say, right, what's the, don't assume like for like is correct. I think much like the public GPs, who are still the business owners in the majority of cases, have various views based on their experiences, background, prejudices possibly on the value of different R staff. And I think that what we have now with newly qualified GPs being able to be employed is the opportunity for people to, to move their organisation forward the way that they see best, and maybe not always based on evidence and things like that. What I would say alongside that is it is a complete travesty that in this country you will spend literally hundreds of thousands of pounds to train and educate a GP through medical school, and then 5 years minimum of postgraduate training, and then have them unemployed. And I think that is one of the worst examples of workforce planning I've come across. I mean, and that goes for other professionals, but genuinely a GP somewhere between £250,000 and £500,000 to train, and then we've got thousands that are unemployed. And, you know, just in my area in North Bucks, I know that there are at least 3 really well qualified, newly qualified GPs who qualify on the 5th of August and don't have a job and can't find locum work.
I agree with you, George. It's one of the most perverse unintended outcomes in healthcare that I've ever seen, because 3 years ago, locums could name their own price to come and work for you guys in practice. Now, locums have disappeared, they've applied for jobs, and we've got a surplus of GPs. Yeah. Who planned that?
And still not enough appointments, I'll say that as well.
Still, yeah, absolutely.
You know, it's not like we say we don't need GPs because, you know, there's plenty of capacity in the system. That's not what's being said.
No.
Thank you. I've got one question in the chat, and then I think unless anyone has any other questions, we can draw to a close. So, as an average, what percentage of patients are eligible to be seen by another practitioner other than a GP?
So, I mean, I think it's not eligibility. I would say that it's about the situation. So in certain situations, for every patient, there's a situation where another practitioner is the most appropriate person. So I haven't brought along a social prescribing link worker today or a care coordinator, but, you know, they have enormous roles in supporting some of our most complex and frail patients, particularly in care homes and patients who are end of life. So, you know, we have a group of wellbeing roles at the Swan network, and they basically coordinate every patient who has a do not resuscitate order in the practice. That's not to say that the GP's not involved and other people aren't involved. They're heavily involved, but these roles are you know, essentially playing a key role in coordinating, you know, other professionals, social care and those areas, you know. And within our team, you know, when people say to me, oh, I think I might need a wheelchair or I need some help, you know, some extra aids in the home. I mean, I don't have a clue where to go and how to get access to that, but I have people in our team who do, and they're really important. You know, so I would say everybody in, you know, every patient, there will be, you know, a situation or time where it's more appropriate for them to see, you know, another practitioner rather than a GP. But there are also some situations where the GP is the best professional, and they're the cases we need to make sure kind of have that strong GP involvement. And a lot of those are based around continuity and where people benefit from that continuity.
Okay, thank you. Frank, did you want to come in?
Can I just build on that question, the one about GPs or other professionals? It's in the stats that practices collect, and I'm just trying to remember my own practice 3W. I think it's something like 60, 65, 35, something like that, appointments with GPs as to other professionals. But remember, the other professionals will be nurses, practice nurses. So whether you can ever get to the bottom of ours appointments as distinct from traditional GP and practice nurses, I'm not sure. I don't know whether George would have the.
So we can. I mean, I haven't. I've got that data for our practice of how many people are seen by each individual, to be frank, right down to that level. We do, in, you know, our sort of public comms tend to split it into GP and non-GP because that's what people ask for. But yeah, I mean, you know, that information is, I don't know whether NHS England collect it, but they collect something called GPAD, GP appointment data, out of each of our systems that's pulled every month, and that breaks it down by professional type as well. So that data is definitely out there. One of the things I will say is, you know, whilst with all of these roles, as Helen alluded to, they're all kind of working under the supervision of a GP. They're all Majority of them are regulated roles, or a huge proportion, but they're not independent. So Rimple's a vastly experienced pharmacist, and certainly I would ask her a lot more questions than she would come to me about if we worked in the same network. But Rimple still works under my license effectively. So what that does mean is that there is a reduction in those GPs that are working in these MDTs and how much time they're spending face to face. So I have a bigger proportion of my time supervising Helen, for example, who at the end of every day, at the end of every morning and afternoon, has a couple of slots blocked off so that she can discuss any patients that she wants to. She doesn't very often because she's been doing it a long time now, but that has to be available. So that's another kind of consequence that we have to be mindful of, and kind of makes it even more important to try and get these unemployed GPs into practice.
Thank you. So I don't think we have any other questions. So we'll draw to a close, but again, a really big thank you to George, Molly, Helen, and Rimple. Really appreciate you coming along. It's been really helpful and informative. So thank you very much. And for anybody watching, we will put this up on our website as soon as we can get the transcription done. Okay, thank you.
Thanks.
Thanks, everybody. Bye-bye.